everybody's least favorite case probably across the board, but as a colorectal surgeon, not mine. I actually really like doing these cases because I actually find the anatomy of the anal canal and anal fistula physiology anatomy actually pretty fascinating. So let me take you guys into my operating room and show you what we're gonna do for this patient. All right, so before I show you the operating room, let me show you the anatomy of an anal fistula. All right, here we go. So we have the rectum. That's the dentate line. These are the buttocks. And somebody comes in and they have a big boil around their bottom. So generally what we have to do is we have to drain this first, and then under anesthesia, we're gonna look and see if we can find a fistula to the inside. This is a tunnel to the inside. And generally most abscesses start with a fistula. Sometimes these go away, other times this persists. If this is a patient with a recurrent abscess, so I'm suspicious that there's a fistula. So we're gonna drain this and then we're gonna try to tunnel back and see if we can find the fistula. Okay, so now that we have that settled, let me show you the setup. So this is our surgical setup, kind of simple and straightforward. Over here we have our drapes and our gowns. We have a little lubrication right there so that we can be nice and gentle. A little suction and electrocautery to help us get control of any kind of bleeding. Once we drain the abscess, we then go ahead and use these fistula probes. These are little probes that they're actually lacrimal probes, and we use them for anal fistulas, and this allows us to kind of tunnel back from the abscess to the internal opening and see if we can identify the tract. We also use a little bit of hydrogen peroxide that we inject through a little catheter into the fistula to see if we can find it. Once we find it, then we use a seton. This is a little vessel loop. It's a tie that allows us to kind of circle around and tie a rubber band around the fistula and allow it to drain loosely. Right, so to demonstrate out a little bit better, I'm going to show you this is how it works. Basically, we take this tie, which is a vessel loop. This is a draining seton, and we go ahead and tunnel that like this from the outside to the inside, right? And then we pull it through, and we'll kind of secure it to itself like this. So what happens is one side of this drain goes through the tunnel in the tract, and then the other side comes out of the anus, and then we tie it to itself like this with some ties. And so you end up with like this little kind of like taily thing sticking out of your bottom. People always worry about the seton because they hear of cutting setons and how those can damage the sphincters. When we place these setons, we actually place them loosely, intentionally, just to drain the infection, to not let it recollect and recur. And we place it loosely so that it does not cut through the muscle. You will feel the little thing poking out. It's generally not painless to have that there. And some patients live with these for years, especially in the setting of very complex fistulas or in the setting of Crohn's disease. Some patients can actually have these long term. So they're very doable, especially if it's used as a bridge from a drainage procedure to a definitive operation to ultimately repair this fistula in a sphincter preserving method, such as a lift or a flap or some other alternative technique that does not involve cutting in and draining the muscle.